All yours.
Hey, good afternoon. Happy Thanksgiving. I'm Matthew Delaney. I'm a professor of emergency medicine at the University of Alabama at Birmingham. And this talk was supposed to be called High Stakes Back Pain. And as I was thinking about it, we are going to talk about the high stakes causes of back pain. But I wanted to broaden it out a little bit because the vast majority of the patients that we see, no matter where we work, whether that's primary care office, urgent care, emergency department, we're going to see a lot of back pain. And really, we need to do two things. One is look for the high stakes causes of back pain, but also figure out what do we need to do for the vast majority of patients who have ultimately a benign cause of back pain. And so really, I think it's best described how to heal the masses, low back pain in the 21st century. We'll keep it really simple and hopefully clinically applicable. There are four things that I want us all to talk about and walk away with. This is really, when you distill down the literature, this seems to be the themes that we see again and again. Number one, backs hurt and we don't know why. That sounds very grim, but that seems to be the truth. We do need to find the few types of back pain, that small subset of patients that need us to do something urgently or emergently. The third thing is when it comes to management, really we can't do much to fix backs. I know that's also grim, but that seems to be what the literature tells us. And then we're gonna end with a little kind of hopeful homily for the holiday season. And I think we can change the discussion around back pain with patients. And honestly, short of a surgery for the few cases that need emergent surgery, changing that discussion may be the one thing we can do that really consistently can help patients do better with back pain. So let's dive in. Goal number one, backs hurt and we don't know why. Back pain is everywhere, and the stats I find to be staggering. 80% of us will have back pain, a major episode at some point in our life, to the point that we tell somebody miss work, go to a doctor. If you look, this is about 5% of the population in the US each year. Second most common reason people go see their primary care. Top 5 reason that people go to the emergency department. So backs are problematic, and this stat blows me away. At any given point, 1% of the US population is on disability for short-term disability for acute back pain. 1% is on temporary disability for back pain. So 2% of the population is disabled from a back pain standpoint at any given snapshot in time. And when you look at it, a lot of us have back pain. Very few of us get a specific diagnosis or will ever need surgery. So it feels kind of hopeless. Oh my gosh, nobody knows what's going on. There's nothing to do, but the odds, and I tell patients this almost every time I see a patient with back pain, at 4 weeks, there's basically a 75% chance you'll be back to normal, fully functional with minimal pain. And if we bump that out to 3 months, 93+% of patients who have back pain are gonna be totally back to normal. So it can be very disabling. I'll be the first to admit, when my back hurts, I feel like the world is ending, but we have to kind of put it in the right context that rarely is there something bad causing the pain. And even if we do nothing but give them a little tincture of time, most folks will get better. And this is not a modern problem. And I love the history of medicine because there are a lot of missteps, but actually there are a lot of echoes of the past that we can pick up. So back pain has been documented since as early as 1500 BC. This was written on papyrus. It was discovered more recently, so 3,500 years after this was written, this was translated for the first time. And this comes from Sanskrit. And it's basically talking about a patient comes in with back pain, we're gonna examine him. And when you push on his back, it hurts. And they say you have an ailment of your spine, which after this hour, I think that's the closest we can get to a diagnosis for a lot of patients is, yeah, your back, your spine seems to be hurting you. And then they said the treatment is to put him flat on his back. So this is something that we're still saying things like this today. I would argue the outcomes are just about as grim as they were back in 1500 BC. And let's kind of walk through the history of medicine and see the missteps and the correct steps we've made when it comes to back pain. So the best kind of historical medical advice I could give would be don't get sick before 1500. Really, it was just crazy things that led to increased rates of morbidity and mortality. Basically, if you saw the doctor, there was a good chance the doctor was going to do something that might lead to your untimely demise. In the 1500s, the gears start to turn and we start to see kind of the first glimmers of modern medicine. So there was this idea of circulation. And then in the 1600s, there's this idea that if you were sick, maybe it was coming from an underlying disease, which now we kind of take for granted, but this is not that old of a concept. And then the whole notion that the disease has specific signs or symptoms. So if something's bothering you, we're going to take that constellation of data points you give us and look for the thing causing it. I love the term lumbago, Latin for loins. So this comes out in the mid-1600s, this idea that, I don't know, I can identify that this part of your body hurts, we'll call this lumbago. And then the history of medicine dives into this whole pursuit of rheumatism. And basically the idea is you've got these evil humors floating around in our bodies, and that when the humors get in the wrong spot or get too hot or too cold, that's what causes diseases. And we really latched onto that within the house of medicine. And one of the things that's very clear as you look at the history of medicine is that we've been unfair to females since the start of documented medical history. And so this idea that, well, you got rheumatism, and it must be because you've got cold phlegm in your muscles. And so the idea would be that you get counter irritants. And what you see here, this is a metal rod that they would heat up in the fire, and then where you hurt, they'd put that there with the idea being we'll warm up the evil cold humors. Laxatives are involved and cupping was involved. So really we kind of wandered in the wilderness until about the 1800s when it came to making a diagnosis of what actually is going with your back. In 1866, we had the first report of what was called railway spine. And this is a fascinating thing to me. So this is the first time in recorded history that trauma was connected to pain. And really what was happening is that railways were becoming more popular and tickets were becoming more affordable. And so people would pay that, whatever, $1 to get on the railroad, and the railroad would they'd derail, they'd get in wrecks a lot. And so people would whip forward and backwards. And what they developed, we would now call a strain sprain, or we'd call whiplash. And so people started to say, hey, I was fine, I got on your train wrecked, and now my back hurts. And so if you were a male patient with a railway spine, it was thought that you had trauma. If you were a female patient, they'd say you were just being hysterical, which again, it's taken us a long time to start to try to treat the genders equal. But this really kind of kicks off a lot of focus on what do we do with back pain, because pain was now tied to money in a lot of cases. Around the same time, a couple years later, we started to see x-rays, and basically we went crazy with x-rays. If we could x-ray it, it was getting x-rayed, and people started to kind of say, well, that bone looks weird, that facet articulation looks weird, let's try to do something. And the answer seemed to be, in the 1890s, if you're having spinal surgery, you were chancing death. This is pre-antibiotics, this is not a good time to have surgeries, and shockingly, doing things based on primitive x-rays didn't improve patient outcomes. In the 1900s, we start to look at the role of bed rest, which we'll talk about kind of the modern literature behind this later. In 1900, 6 weeks of bed rest for acute lumbosacral pain. And then in the mid-1920s, it was thought, man, if you're not resting enough, that's what's going to lead to chronic pain. In the 20th century, we also started to see the increase of disability tied to back pain. And so if you look at soldiers who were wounded in World War I with back pain, they were out of or off the front lines for about 2 weeks. By the time World War II comes around, the average time you'd be off if you had an injury to your back was about 2 months. Similar injuries, similar patient population, similar mechanisms. So we started to see that for whatever reason, there are probably multiple reasons, patients were getting more and more symptomatic and having more disability associated with back pain. 50s and 60s, there weren't a lot of medical advances. We started to get in this biopsychosocial model of illness. Again, this was very kind of heavily slanted towards female patients. And then the 80s and 90s is when CT scans and MRIs came around. And this was a game changer, although we'll walk through the evidence behind it, maybe not a great game changer. And it was this idea in the mid 80s, well, if we can see degenerative discs, we have really good pictures. So if we see a bulging disc, that must be the cause of your pain, which we'll go through later. Isn't necessarily true in a lot of cases, but often, when you're a hammer, everything looks like a nail. And so when you're seeing bad discs, the surgeons were saying, well, we can do stuff with bad discs. We actually make a lot of money doing stuff with bad discs. So rates of surgery increase significantly when you start imaging discs, although the outcomes for patients stayed about the same. This is a quote from 1991 that I think should just be republished so we can have it in 2024, because this sums up exactly where we are. In the past, much back pain management has been a series of fads and fashions. Many of the treatments have eventually been discredited, not until they were provided to many patients at a high cost with occasional morbidity. This is what brings it home. At least today, we are better aware that we know that we don't know. So backs hurt, and we really don't know how to fix the vast majority of backs. So that's point one. As grim as that is, that's the honest answer, is we've tried a lot of things. Still, back pain is a major, major problem for 2% of the population at any given point. So what about the patients that we need to kind of do something other than just say, yeah, it's going to be time, maybe rest a little bit and you get better. So number two is find the few patients who need fixing. And we're going to talk about exams, tests, labs, and then we'll talk about treatment. What actually can we do to fix backs? And the answer is we can't do much other than just tell patients, hey, it's going to take a little time for this to settle down. So goal two, find the patients that need fixing. And depending on where you work, this can be really challenging. This looks like it was taken in my emergency department a couple days ago. And so the reality is we have tons of patients. A lot of these patients report back pain. But statistically, a very small subset are going to actually have an ominous cause of back pain that we need to do something about. So how do we kind of risk stratify patients who show up in our clinical environments to say, hey, I think you're fine, versus, hey, I'm a little worried about you. I think we need to do more. So when it comes to history, the literature says look for red flags, and we'll dive into that. And then the exam really should mirror our history. We're looking for evidence of badness in or around the spine on our exam. And that's really the key thing. When you see a patient with back pain, we got to think, are you in the minority of patients that has something bad, or are you going to be fine no matter what we do? All of the guidelines, most of the literature about back pain talks about, well, just look for the red flags. And if you can find a red flag, that would suggest you have an elevated pretest probability of having something bad in your spine. And in fact, the chance of us finding something bad in your spine doubles if we have one red flag. So when I first read that years ago, I was like, well, that's pretty simple. The problem is that as of a year or so ago, when I last looked, there are up to 74 purported red flags for back pain, which from a practical standpoint, there's zero chance I'm going to be able to go through all those or remember all those with a patient. So this idea of red flags, sure, that makes sense, but what do we do with this information? And really we can distill it down. And when you think about red flags, all of the 74 red flags kind of distill down into this: do you seem like you could have something pushing on your spine? So we're thinking, do you have an infection? Do you have a tumor? Or do you have like a bony problem or a disc problem? And then the other part is your pain weird or unusual? So something pushing on your spine, do you have weird or unusual pain? So let's kind of walk through this. And this is how I think about it. Rather than remembering 74 red flags, I try to use a little bit of common sense. So infection, and we can make this real simple. Do you have a story that makes me think you could have an infection? Fever, chills, all the stuff we went to school to be taught. The classic signs for infection should increase our suspicion there could be something brewing there. Then we get into the other things. Do you have a good immune system? I think we're pretty good at picking up the overt immunocompromised patients, but even a patient who's got moderate diabetes arguably has some degree of immunocompromise. So we have to look for that kind of soft immunocompromised patient. And then do you do high risk things? And in the US, we're seeing increasing rates of fentanyl use, IV drug abuse. And so it used to be even 15 years ago, we didn't see many cases of osteo in the spine or epidural abscesses. We're seeing a lot of these, and these account for a lot of bad outcomes and a lot of medical legal actions. And so think about it. Does the story sound like infection? Are you at a higher risk of getting an infection than somebody else? And then do you do things or have things happen to you like spinal surgery where it's more likely compared to somebody else that you could have an infection in or around your spine? Cancer, look, again, I'm a simple guy, make this simple. Do you tell me a clinical story that makes me think you could have cancer? Night sweats, gosh, I've lost 30 pounds, I don't know why, I have a history of cancer. Just don't overlook the obvious clues that patients may give us. Then also, do you have cancer? Do you primarily have a cancer? Any patient with any kind of cancer that says I have new back pain, I may not go full court press MRI, I'm at least gonna pause and think, well, that's weird that you have new back pain. And we think about metastatic cancers, and unfortunately a lot of cancers, and especially prostate cancers, we make the diagnosis when we find the mets in the spine. So again, make it simple, broad brushstrokes. Do you seem like you have cancer? Do you have cancer? Or is there something cancer related in this whole story? Weird pain, again, patients will tell us these stories. It's just up to us to kind of latch onto the things that really matter. Age matters. So if you're under 18 and you get back pain, that's weird. Now, if you fall off your bike and your back hurts, sure, kind of know what to do with that. But if a 16-year-old female gymnast comes in and says, I have really bad back pain, we got to think about, do you have something like a traumatic spondylolisthesis? You know, it's unusual for a teenager or child to say, my back hurts without there being something causing it. And also over 50, which I won't say is old, but I will say it is weird to make it to 50 years of age and not have had any episode of back pain before. So if a 55-year-old comes in and says, never happened before, I've got really bad back pain on my legs, I'm gonna pause and think that is kind of weird. Duration, so has this hurt for a long time? Remember, at 3 months, 90+% of patients are gonna get better, but if you're getting 4 to 6 weeks in and the patient's not getting better at all, that's a weird timeline. Back pain should get better quicker than that. Not totally better, but you should be improving by then. And then does it hurt at night? This one's a little bit stranger because I think everything hurts a little worse at night because you're not distracted. But if you're getting pain that's waking you up, again, if a patient says that, at least pop up something in your brain that says that's a weird way for somebody to report that they're having pain. One of the forgotten red flags is arteriovenous malformations. And this was way off my radar screen, but the literature is pretty compelling that this runs in families a lot of times. And a lot of times, even patients with lower healthcare literacy will know that they have this in their family history. And typically this will present between 20 to 60 years of age. And it's a pretty rapid progression of symptoms because the AVM either grows, gets a big aneurysm around it, or bleeds. And so I've started just asking patients, hey, I know this is weird, any history of aneurysms or AVMs in your family? And we've actually found a couple of cases where they had an AVM that they wouldn't have known about otherwise. So this can look like Cauda-Equina syndrome when it presents, but again, if a patient comes in, abrupt onset of pain, it's weird, ask a couple of basic questions, and I think we actually can risk stratify patients pretty decently. The other back stuff, and this is what I hate, I remember reviewing for the emergency medicine boards, and they were just grilling us on what are all these other causes of back pain. Here's the bottom line, be a good clinician. If we just get a good history and do a decent physical exam, we should be able to tell if this patient has peptic ulcer disease versus back pain or pneumonia versus back pain. So I'm not a mnemonic guy, I'm not a list guy. We all know that our backs can hurt and then a lot of other things in our body can cause pain that a patient may say is back pain. That's why we're paid to take care of patients. Just ask the questions. Don't overlook obvious clues the patients are giving us. And how do we chart this? So that's one of the big things that is increasingly clear to me, is that as more and more back pain cases get litigated, a lot of times someone will do a really good exam, do a really good encounter with the patient, but doesn't give themselves credit in the chart. And failure to consider is one of the biggest medical legal allegations. Hey, Delaney, if you'd only thought about the bad stuff, you would have caught this. And so what I do is I've got a dot phrase or a macro that I put in my charts. And it's true, I want to represent what I've done. I say my patient has no history of IV drug abuse, no spinal procedures, is not immunocompromised, there's no history of malignancy, no family history of arteriovenous malformation. So basically what I've done is I've said, I've done my normal history, nothing worries me. Now I'm going to specifically call out some of the things that are out there where the incidence is increasing, specifically the infectious complications related to IV drug abuse. And I'll put that in my chart. Now, will that keep me from getting sued? No, I can get sued for anything. But I do think if I were to miss a case of an epidural abscess and somebody picked up the chart and said, well, he got it wrong, but he thought about it, that's actually a pretty good level of protection from allegations of malpractice. And this is tough, but the longer I do this, maybe just the more mistakes I make, I think really trusting our history seems to be one of the keys. And I would say we all know how to get a good history. But in the rush of a shift or a clinic day, it's easy to brush off the clues patients give us. But we do have pretty robust data that says, fewer than 1% of patients that show up are going to have an ominous cause of back pain. But in that 1% of patients, we can actually get the risk factors. We can appreciate that they were at an elevated risk if we just listen and ask the right questions. So it's not hopeless in terms of making the diagnosis. I think we just need to use common sense and kind of break out of our strictly kind of medical, data processing mind. Physical exam, one of the big things here is it doesn't matter what diagnosis you make if it's a benign cause of back pain. You could say strain, sprain, spasm, it doesn't matter. The key is to just look for trouble in the patient's spine. So what are the key parts? What does the literature say is helpful in terms of how do we examine patients with back pain? Vital signs they say they're vital. Yeah, they are sometimes, but they can also be misleading. So I would never overlook a fever in a patient who has back pain. If you have infectious complications, you see, if you've got an epidural abscess, 83% of those patients report a fever, but 17% of patients with an epidural abscess don't have a fever. So fever plus minus, one of the studies that's really interesting is out of emergency department patients with back pain, 10% of patients who had benign back pain actually showed up with a fever. So I don't know what to do with it. I wouldn't overlook a fever, but if you're looking for a fever and saying there's no fever, there's no infectious complication, I would say that is not a safe way to interpret the data and to evaluate the patients. Physical exam, I visualize and touch the whole spine. There are a couple of reasons. I want to look for trauma, although this is not a high yield exam. The honest answer is that this may be a bit of a parlor trick of medicine. I think there's a value to touching patients, and they said that their back hurts, so I want to examine it. But we don't have studies that tell us at all how accurate this is, because you push different than I push. And I don't know if you push and they say ow, and I push and they say oh, it's a little uncomfortable. I don't know what that means, but it does feel medical. And so I would say it's not that you got to thoroughly push in everybody's spine, but I think it's reasonable to palpate the spine. I have found a couple of METs to the spine just from pushing. So it takes 10 seconds, it's easy to do, it feels medical. Do you feel spasm? And I get this a lot from learners, and I think it's cool. Somebody comes out and says, I know what's going on, they have spasm in their back, they're having back spasm, I felt the spasm. Well, the problem is when this has been studied, the inter-rater reliability is horrible. So if you push and say, yep, I feel spasm, and I push and say, I don't feel spasm, the literature tells us that, number one, we don't consistently agree, is there spasm? Yes, there is, or no, there's not. And then even if we're saying, like, yeah, we both think there's spasm, we can't even get right or left correct. So I have no problem if somebody wants to say, I think they have back spasms based on my exam. That's fine. I don't base major decisions around this. So if somebody has a fever, history of IV drug abuse, and somebody says, well, look, I think there's spasm on the left, I would say they could have that, that's fine, but we also need to think about what are the other ominous causes of this. So if you're better at spasm, that's fine. The literature just says we're all pretty bad at figuring out spasm. Neurologic exam. A lot of us hate the neurologic exam. There are a lot of parts to it. The cranial nerves are kind of confusing. I never liked that stuff. But really, when we're talking about a patient with back pain, let's make it very, very simple. Is something pushing on this patient's spine? Does our exam suggest there's something pushing on the spine? So every patient I see gets strength, sensation, and some form of reflex testing. 100% of the time, that's what they get. Every patient I see, I ask about bowel or bladder. Now, I will check, and we'll talk about how do we check in some patients, but I screen them with any issues with your bowel or bladder. If you're gonna chart this, cranial nerves 2 through 12 intact does not need to be on our charts because that's not what the back controls. And so I've seen plenty of cases gone bad where the only neurologic exam documented was cranial nerves 2 through 12. And I always feel kind of sad. I'm like, gosh, you documented all this detailed information that had nothing to do with the presenting complaint. Walking patients is amazingly helpful. There have been lawsuits that have been defended strictly because the physician was able to say, I saw him walk, and if you can walk, and we'll break this down, if you can walk across this room and get up from a chair and do it, I would bet the bank that your spine and your nerves are working decently well. And then I'm a simple guy. I'm from Alabama. Document like a normal person. Just tell folks what you did so that if something goes off track, on the rare chance it goes off track, the next person to pick up the chart can say, Delaney got this wrong, but I actually can follow the dots that he connected, and I think this care was reasonable. So motor exam, can you walk? So heel walk, toe walk, squat and rise. Again, I'll have a patient say, hey, can you get out of a chair? Can you go on your toes? Can you go on your heels? No patients like to do this when the back hurts, but I've now just tested L4, L5, S1, and L3 through L5. So that's a very easy, quick way. It takes all of 5 seconds for the patient. One of the things that I'll see a lot, and this happens with learners, they'll say, I couldn't get a good neurologic exam because the patient couldn't walk. That's true, but what we have to determine is, does the patient not want to walk because they have horrible pain, or can they not walk because there's an issue with their nerves? And so again, just isolating out the muscles lets us get a good exam even in the patient who may not be able to walk. Sensory exam is important. Now, an abnormal sensory exam doesn't mean we're off to the operating room or necessarily getting an MRI, but one of the things that I think a lot of us miss is the chance to get a good sensory exam. And the key here, and I know this is a hassle, patients need to take their pants off and take their socks off. You really cannot check the dermatomes of the leg or the foot if the patient have work boots and jeans on. So I do go through the hassle of taking patients' socks off. I know it's kind of gross at times, but it does give us helpful information. I don't always do perineal sensation for a lot of reasons. Number one, that seems like a weird thing to put the majority of patients through. But if I'm getting clues from the patient that make me worry, that is when I'll do a rectal exam, do a perineal sensation as well. But for most patients, if I can just check the dermatomes of your foot, that gives us a good amount of information. Reflexes, I typically will do knee and then I'll occasionally do Achilles. I would say that doing an anal wink is probably not as helpful of a test as some of the older texts would suggest. But I do cursory reflexes for most patients. And again, lack of a reflex doesn't necessarily mean you have an emergency. So I do strength, sensation, reflexes in some fashion for all patients. But out of these, the signal is strongest that strength is what we really need to focus and be sure before a patient leaves that we have evaluated them and we're convinced that they have normal strength in their lower extremities. Bowel and bladder, this is where it gets messy. And I'd say my caveat is if you're looking at a weird exam or a weird story about bowel and bladder, the better part of valor would be to get an MRI. I know that puts a lot of people, the hair on your neck sticks up and you get very angry. But the literature would say that bowel and bladder stuff does get a little bit messy. So how do we think about this? So we want to check rectal tone, check perineal sensation. If a patient says, yeah, it's weird, when I wipe, it feels strange. That's a patient where I am going to get a rectal tone. I'm going to try to get good perineal sensation. Bladder comes up a lot, and patients love, they'll never say it in just their history, but if you say any issues with your bladder, you have been peeing a lot more recently. Well, really what we're trying to hone in on in the setting of back pain is, do you have overflow incontinence? And the classic story should be, yeah, my back hurts really bad and I lost control of my bladder. That's a great story for overflow incontinence. What I'll often get is, my back hurt so bad, I knew I had to pee, I was trying to get to the bathroom, and I peed on myself. I would say that's a bad afternoon, but that is not a sign of overflow incontinence. And one of the things with bladder, because again, we get a lot of patients that will endorse bladder symptoms. In the literature, in terms of what bladder symptoms really count or should increase our concern, literature honestly is messy, but the most reliable thing we can do is get a post-void residual. And this has been a game changer for me. So if I get a weird story from a patient, yeah, I'm peeing more, or maybe I lost control of my bladder, I have them pee. And then what I'll do is I'll check their bladder. And so the easiest way to do this is with a bladder scanner or an ultrasound. So say, I want you to go pee, I want you to pee as much as you can, really drain your bladder, and then have the nurse or the tech bladder scan them. And you can do it yourself, but this is an easy thing to offload. Have somebody check their bladder. And a couple different formulas you can use. A lot of this is automated, but if the patient has less than 100 cc's of urine after they've peed, the chance that they have significant urinary retention is very, very low. And this comes out of the neurosurgical literature. So if you can show that a patient, even with risk factors, even with a weird story about urinary incontinence, has a post-void residual less than 100, the chances that they've got urinary incontinence or urinary retention because of something in their spine is very, very low. That being said, Cauda-Equina syndrome, which is kind of what we're circling around here, is this something big pushing in the center part of your spine. Cauda cases are tricky and they don't all read the textbooks. And so if I got a patient that says, I did pee some, it's kind of weird, I get a bladder scan that shows me 150 cc's, what I've shifted to do is I'm just gonna get that patient an MRI, because that's an exam that's hard to justify not going further. But if you've got a stone cold normal bladder scan in that patient that gives you a little more concern than the other patients, I would say under 100 cc's, that patient should be safe. The Vegas odds are overwhelming that this is not urinary retention from their spine. Bonus exam, straight leg raise test. I like doing this. This is kind of, again, I feel like the more you can examine patients, the longer they think you're at the bedside, and studies show that that means that they think you're more empathetic. I try to be empathetic, but I'll take everything I can get to make them think I really am being empathetic today. And basically, this is a misunderstood test that is looking for tension in the sciatic nerve, and it tries to show is there nerve root irritation. It's fairly sensitive. It's not that specific because there are a lot of false positives. And it probably is because a lot of us are doing the test incorrectly. So really what we want to see is, do you have a reproduction of your pain when I lift your leg, the affected side, between 30 and 60 degrees? Now, what a lot of patients will say is the second I touch their leg, ow, that hurts. I would say that's just a painful leg. That is not a positive straight leg raise, because if I'm not lifting and I'm not up to 30 degrees, I'm really not increasing tension on the sciatic nerve, which is what we're looking for. And so the pain also, to have a truly positive straight leg raise test, should radiate down that leg. Again, we're looking for that nerve root irritation, and anything that increases tension on the sciatic nerve should make it worse. Anything that decreases tension on the sciatic nerve should make it better. But again, it's not just pain with movement. And this is the real kind of players move, the parlor trick, is the crossed straight leg raise test. I don't do this all the time, but the interesting thing about this is a very sensitive test for HNP, or herniated nucleus pulposus, which is kind of bulging disc, protruding disc, common cause of nerve root irritation. And basically they'll have pain on one side. You go to the other side, do the straight leg raise, and if it reproduces pain on the side they were complaining about, that's actually very specific for herniated nucleus pulposus. Doesn't mean they need an operation, but if you're getting a positive straight leg raise, it's easy enough to try the other leg, and if you get a true positive there, you got a pretty good idea of what's going on without doing any imaging. This takes all of 30 seconds to do at the bedside. So history exam, get credit for what we ask for. When I document this, I say exactly what I did. They went on their heels, they went on their toes, they walked, sensation across the foot is normal, no bowel or bladder issues. But again, the longer I do this and the more I get burned on, gosh, that story didn't really seem like it, yet they had something that needed an operation. If you're getting a weird exam, and you see a lot of back pain patients like most of us do, trust kind of your spidey sense. If you think the exam is weird, the better part of valor is just to get imaging for this patient. So that kind of leads us to testing. What do we need to do? X-rays. We love to do X-rays on the back for back pain. We can probably stop doing most of these. So in the absence of red flags, again, nothing weird in the story, nothing weird in the physical exam, there really is no indication to image them within the first 4 to 6 weeks. Specifically, you don't need an X-ray. Now, we'll go off the record. Is there a therapeutic X-ray? Is there the patient that says, I'm here for an X-ray on my back? Yep. And sometimes that patient is only going to be satisfied if you can X-ray the back. I get it. I've done this long enough to know that that patient exists and often shows up in my clinic. But I don't make decisions based off X-rays outside of something that's glaringly abnormal. And I tell most patients, we can get an X-ray, but we're not going to do anything with it. And honestly, you're going to get better in 4 to 6 weeks. We don't need to get X-rays of you. And really, again, multiple studies say if you got no red flags, you got a decent exam, the chance we find anything, not something that's going to paralyze you, but that we find anything, is greater than 1 in 2,500. So who needs X-rays? Is there a role for them? I think that there is. And if you look, the red flags that would be helpful for X-ray would be the young and old patients, right? It's the gymnast who's 16 who has traumatic spondylolisthesis. X-ray shows that well. It's the 55-year-old who's got new back pain that's coming from a met from their prostate. Fractures, mets will show up fairly well in X-ray. So if you're thinking weird pain, X-ray might be the right test, and these are the ones where I will get it because I'm picking up on the weirdness as the red flag. What should we order? My system makes this very complicated. You type in like lumbar and you get 40 different views that you want. AP and lateral are going to pick up almost all the pathology you need. One of the pitfalls, and especially if you're in the emergency department, is that a lot of us don't have 24/7 radiology coverage or in-house radiology coverage. So I've worked plenty of shops where you're working solo coverage overnight, you got to get an X-ray of the spine, and you have to read that X-ray. So spine X-rays aren't hard, but they do take a little bit of repetition to get them down. So if you're looking, thinking, that is weird pain, I'm worried about a bony issue, and you don't have radiology coverage for the X-ray, CT scan shows bones well. It's more radiation, it's more cost to the patient. There's more incidental findings. But again, that's kind of the caveat with X-rays is if you're gonna get them for the right patient and be sure you know what you're looking at. Who needs a CT scan? CT is good for trauma. So most motor vehicle collisions, if I'm gonna image a patient, I'm gonna do an X-ray. Good for fractures. This is kind of the lazy man or the single coverage ER docs workaround. we're not on the hook to read our own CT scans. If I'm concerned, a radiologist somewhere will read that for us in most shops. And if they can't get an MRI, and then spinal surgeons love CTs post-op, the literature doesn't tell us exactly why other than the surgeons like them. So if you get a call from a surgeon saying, hey, I just operated on this patient and did a fusion, can you get a CT scan? That's a reasonable thing that they'd be asking. They prefer that over MRI in a lot of cases. That brings us to MRI. And this is the elephant in the room because a lot of us have access to MRIs. And the issue isn't can we get it, it's do we need to get it? Is this a resource we need to tie up? And really, the number one question to ask before you get an MRI in an emergent or acute setting is, could this patient have something pushing on their spinal cord? And I think if you're in the ambulatory world and the answer is yes, I would argue send them to the emergency department, because if you think something's pushing on their spinal cord to the point they need an MRI, that is an emergency until proven otherwise. So things we think about, cauda equina, big bad discs in the back, abscesses, METs, AVMs, MRI is the test of choice for all of these things. If you don't think something's pushing on this patient's spine in a way that could hurt them, the patients don't need MRIs. The literature is very clear about this. So why don't we just get more MRIs? I work at a shop that's got 6 MRI machines in one building. It seems fairly easy to get an MRI. Well, the problem with MRI is that it's unreliable information, and consistently when it's been studied, getting MRIs does not improve patient outcomes. So why not just get it? I feel like our culture does think more is better, right? We can do all this stuff. We can do an MRI machine. Wouldn't we put you in the MRI machine? Wouldn't it be better? The problem is we don't know what to do with this information. So if you look at truly asymptomatic patients, when it's been studied, up to 80% of patients, no symptoms, this is just in a study, had a disc bulge. 27%, over a quarter, had a disc protrusion, up to 30% had herniated nucleus pulposus. Again, we would look at that and say that's a pathologic finding. Well, I don't know, the patient's asymptomatic, the MRI just saw it. And this increases with age. And once you get about 20, the odds are greater than 50% that you're gonna have something abnormal in your spine. So most of us here have something wrong in our back, whether we have back pain or not. So if we image people with MRIs, we find a lot of stuff. And then the question is, all right, well, can we figure out, if I'm looking at the patient and getting their history, and examining them, can I predict who might have a positive MRI finding? And a positive MRI finding would be, it's a lesion on the MRI that correlates with their pain and that is amenable to an intervention. So if a patient says my back hurts, no matter how they describe their back hurting, there is no association between their report of back pain and the odds that we find something on the MRI. If a patient says my back and my leg hurts, at best there's a very weak association. So again, we find a lot of things, but we really struggle to say, are these things actually related to your back pain? All right, MRI in symptomatic patients. So at best, if you look at a bunch of meta-analyses and systematic reviews, there is a very weak association between degenerative discs and the patient's symptoms. And the honest answer is, a lot of us have bad discs, a lot of us have back pain, but when you blind people and say, can you pair this MRI with this patient's story, we can't consistently pair those things up. I know that sounds crazy to say you have a big bulging disc, you've burst your disc in your back, yet we can't connect that with your story. That's just what the literature seems to tell us again and again. But despite the fact that this is a low yield test for the vast majority of patients, we love to get MRIs. So this is a fascinating study in JAMA 2013, looked at 1,000 MRIs that were ordered. Out of that, and radiologists looked at it, is this unfair? Yeah, it's a little unfair because the clinician was doing what they thought was best. Maybe we were, but the radiologist said only 443 of the 1,000 were considered appropriate, and the remainder were split between inappropriate than uncertain value. So the majority of the time, based on this study, and there are other studies that kind of reflect these numbers, if you get an MRI on the patient and we don't have a high pretest probability that they have something in their spine, the chances of us getting anything of value from that test are almost zero. But what happens? It's that whole expression, when you're a hammer, everything looks like a nail. So in the past decade, there's been a 307% rise in lumbar MRIs. More information does lead to more interventions. It's very hard to take a bad MRI to a spine surgeon. There's some ones out there that won't act on that. But if you show up a couple times and say, my back still hurts, here's my MRI, it's abnormal, the literature says they're gonna do something. So along with this rise in lumbar MRIs, there's been this rise in spinal fusion. But look, no improvement in patient outcomes, no reduction in the rates of disability. So we're finding stuff. When we find stuff, the literature says we do stuff with things that we find, yet outcomes are not improving. So clearly we can do better here. This is the wrinkle though. Patients do often just want an answer. So this is the title of this paper is The Power of the Visible, the meaning of diagnostic tests in chronic back pain. Acute back pain is a little different, but it's not that different. Most patients, if you really put their feet to the fire, they want an answer. And there's this notion, this comes from a patient, when physicians can't locate the problem or express doubt about the possibility of a solution, patients feel their pain is disconfirmed. So in all of this, we have to find a way to say, hey, the bad news is your back hurts. The good news is I think you're gonna get better no matter what we do, but we gotta convince the patients of that. Because just saying, I don't know, backs hurt, we don't know how to fix them. I realize that was the number one takeaway from this talk, but we need to have a better script, a better way to talk about this with patients, because patients do want something done. And we'll get there, but so kind of bottom line on MRI, very few patients actually need this test. And arguably this test can hurt the remainder of our patients. So there is no proven benefit if you don't have that kind of concern for an ominous cause, no proven benefit. We find a lot of stuff. We as a profession don't know what to do with the stuff we find, but there are other people, there are specialists that'll say, that's why you drive down the interstate, there are a bunch of, come to my spine center, my laser spine center. The answer is none of them are better at spines than anybody else. That's how they can all say, I'm the one you should come to. But when we put patients on this kind of conveyor belt, we chew them up in the process. So we really, from a standpoint of patient safety, should be judicious with how we use MRIs. I love this study. The question was, does this patient with back pain need imaging? And this was low back pain without red flags, whatever of the 74 they were looking for. And they looked at immediate care versus standard care. And immediate care could include a CT or an MRI. What they found is whether you were in delayed care, whether you were in the immediate care, primary outcomes, pain and function, short-term, long-term, were same between the groups. And secondary outcomes, mental health, quality of life, patient satisfaction, same between the two groups. And I think the most important thing is in this patient population, no serious diagnoses were missed in those who weren't imaged when you took the red flags off the table. So again, if we get a good history, do a decent, not long, but a decent focused physical exam of these patients, and just think, is something pushing on the spine? The idea that imaging is gonna make this better for the patient really is not supported in the literature. Do I need labs? I mean, the honest answer is no. So white blood cell count, is there an association if you have an epidural abscess, are you more likely to have an elevated white blood cell count? Sure. The real takeaway for labs, for all the labs, seems to be don't trust a negative lab. You can absolutely have a horrible spinal infection, have a normal white blood cell count. And what do they call it? The last holdout of the intellectually destitute. So if you want to get a white blood cell count because it's an infection number, fine. I would strongly recommend we not make major decisions based on a normal white blood cell count. Labs, ESR, the inflammatory markers, I think these are getting easier to order, and I'm seeing these ordered by my colleagues. Sometimes I'll even get kind of wild and order one myself on a patient. The answer is the literature isn't caught up to our fondness for ordering SED rates. And so we know that in the cancer world, if you have a high SED rate, which I assume almost everybody with cancer has an elevated SED rate, maybe you have an increased risk of METs. That's not helpful information for any of us at the bedside and the ambulatory side of things. It's extremely nonspecific. If you got an elevated SED rate, is it because you have to have an epidural abscess? Maybe. Is it because the wind is out of the east? I don't know. The literature doesn't know either. So I do not routinely get SED rates on patients, although there may be a role. And this is an algorithm that has been published but has not been validated. And I mention it just because I think a lot of us struggle with what do we do with a patient who's used needles, whether it's dirty tattoos or more commonly IV drug abuse, because their risk of developing something like an epidural abscess is much exponentially higher than people who don't have that risk factor. And the idea is, well, I don't want to MRI every patient who potentially could have an epidural abscess just because they used fentanyl through a needle 3 weeks ago. So can I risk stratify the patients? And basically what this study is trying to show is that, or has looked at is, well, if I've got a patient where they have spine pain, they don't have any obvious findings. So I'm getting my history, I get this red flag of IV drug abuse. I do my exam, I don't see evidence that something's pushing on their spine, but I do recognize that their baseline risk of infection is way up because of this history of IV drug abuse. Can I use things like SED rate or CRP to help risk stratify the patient? And what they found is that in the control group of patients who didn't have infections, the SED rate was elevated in 33% of the patients. And if you looked at the patients who had epidural abscesses, it was elevated in 100% of those patients. So this is very low quality evidence. But the way that I've incorporated some of this is that if I've got a patient where they have a history of IV drug abuse, I'm a little bit worried, but I'm not too worried. If I can get a negative SED rate, if I'm on the fence about should I jump to an MRI or can I get a negative SED rate, I think that's a reasonable path forward. If I get a negative SED rate, their risk is much lower. But that being said, this is a very humbling patient population, so I would say until we get further evidence, you'll see some of this pop up in protocols, but this probably isn't fully ready for prime time, although I think it's something you could incorporate in part of our decision making. Goal number 3, we can't do much to fix backs. I love this because this looks at all the stuff we tried and the answer is we don't really know, kind of do whatever you want to do. So who is the best at managing back pain? we see the billboards, orthopedists versus neurosurgeons versus PCPs, and hell, let's throw the chiropractors in. It didn't matter who touched you, who tried to examine you, who tried to treat you, duration of symptoms, functional outcomes, or the chance that this turns to chronic back pain were the same across all the groups. So is your spine center better than another spine center? Maybe, but you need to prove it, because to date, we don't know that you're any better than the chiropractors when it comes to actually making backs better. So we throw everything else out. What else works? We'll go through this. NSAIDs. NSAIDs probably do work for back pain. They're probably better than placebo, and they do seem to give some short-term relief, but they're not clearly better than acetaminophen. So NSAIDs are good. Topical NSAIDs are great for the patient that can't handle systemic NSAIDs, but do these fix backs? Well, more than placebo, but not in a way that's overwhelming. The downside is that these are pretty hard medicines for a lot of patients to take, and up to a quarter of patients who are on short-term NSAIDs will say, hey, I have a side effect. And a lot of it's dyspepsia, but GI bleeding. Bleeding is a big side effect. And it's impressive, the morbidity and mortality associated with NSAIDs, and it's probably because most of us take ibuprofen a couple times a week for various aches and pains. But in the US, 7,500 deaths a year are thought to be secondary to NSAID complications. Tenfold number of patients have hospitalizations. So I think we know that these aren't benign drugs, but just a reminder, these aren't totally benign drugs. The kind of takeaway for me when we look at the NSAID literature has been that in terms of efficacy, all the NSAIDs seem to work about the same. Very few statistically significant differences. But when we look at the side effect profile and the risk of serious complications, and again, bleed is the big one, ibuprofen is much, much safer than the other ones. And if you look at this, indomethacin is 2.4 times riskier than ibuprofen for patients. So if you're gonna use NSAIDs, and I'm a fan of using NSAIDs if the patient can tolerate them, I would say keep it simple, let's go ibuprofen, because there's no benefit to doing other medications, there's just an elevated risk. Opioids, we'll simplify this because I think we're all tired of hearing about the opioid epidemic. We didn't cause this, we've gotten blamed for this. I get it, that's another talk for another day. It's more of a sermon when I start talking about this. But the real question is not, did we cause the opioid epidemic? Are we gonna create rampant drug abuse because we gave somebody a couple of oxycodone in the emergency department? Probably not, but what does the literature tell us in terms of do opioids actually help the patient? So opioids consistently for acute back pain will beat placebo, they will beat NSAIDs, and they're better than tramadol. Tramadol is a garbage drug that we should never prescribe again. Another rant for another day. But one of the things that's interesting is that opioids don't clearly beat acetaminophen. And there's some kind of tinfoil hat conspiracy thought that the reason we have combination products, hydrocodone with acetaminophen, oxycodone with acetaminophen, the Percocets and the Lortabs, is because when those were studied at doses under 15 milligrams, if the opioid is under 15 milligrams, it struggled to beat placebo, but when you add acetaminophen, then you can beat the placebo. So there probably is some role for opioids in the patient who's just really miserable. And some of this is not, does it fix the pain, but does it alter your sensorium to the point that life is a little more livable? Does your quality of life get a little bit better if we give you this medication? Maybe, but all of these studies are very low evidence. They're very kind of straw man studies. So when they've been studied, you think you could look up a study that says, we gave good doses of ibuprofen compared to good doses of oxycodone and see how people do. Those studies have not been done because there's not a lot of money in a lot of these drugs. And so the best we can say is it's probably better than some medications, but again, we have to balance that with the risk of other things. The risk of addiction, I think this drum has been beat too many times, but it's real. And even with a short course, there is a subset of patients who we're exposing them to this risk of addiction, even with a short-term prescription. One of the big problems that comes up is this idea of, well, we know that back pain is going to last for a while. And again, through the rosiest of lenses, 75% are better at 4 weeks. And so if I'm seeing them in an urgent care in the office or in the emergency department, I may give them 10 to 20 hydrocodones with acetaminophen, but that's not going to last them as long as their back pain lasts. So if I'm going to prescribe opioids, what I tell the patient is, this is this is designed to help you get out of bed and get you over the hump. This is not going to fix your back pain. You're going to have pain for much longer than this prescription would last. And when we shift into, well, okay, after 14 days, is there a role for longer term opioids? The literature is very, very messy. This has not been studied nearly as much as I would think we should study it given the kind of prevalence of prescribing these medications. But we do know that if you're on long-term opioids, there's an association between being on those medications and increased risk of long-term disability and in getting an operation. So there are certainly downsides to medication where the upside really isn't that clear. So what are other things that we throw out at patients? Muscle relaxants, they maybe beat placebos. One of the things that's fascinating is it's overall a poorly understood category of medications. And there are a lot of different ones. We all have kind of our favorites, but when studied, it's not clear that anybody's favorite is better than anybody else's. And there's not a signal to say, well, this patient would do better with this muscle relaxant for this one. I kind of tell patients that what muscle relaxants probably do is almost nothing at the muscular level, but make us a little bit high and a little bit altered, and we don't worry about or think about our back pain as much. So I'm not anti-muscle relaxants, but the evidence for efficacy is pretty crummy. Other things, this comes up a lot. I don't know if this is a Birmingham specific question, but patients consistently ask me, should I put heat or cold on this? And my answer is, I don't know. You can't really blind the studies, right? Because if you put something on me, I'm alive, I have sensation, so I can tell you if it's hot or cold. The answer is, we don't know. There have been positive studies for heat, negative studies. One was uninterpretable. I pulled that study. Let me just assure you, it makes no sense. Cold, no conclusion. So I tell patients, do whatever you want, hot or cold. Doesn't matter to me, probably doesn't matter to your back. Steroids. So there's some nuance in here that I think is important, because a lot of us have practice patterns where we incorporate steroids into kind of treating our back pain patients. So what does the literature tell us? Should we be doing this? Oral steroids, there's really no data to support oral steroids with or without sciatica. Does that mean it doesn't work? No, it just means that we don't have good studies to say, hey, I put them on this dose of oral medications, this kind of boost, this blister pack of steroids. People do, and the neurosurgical literature kind of dances around this. If you give people steroids, they kind of get pumped up. They can't sleep, but they also do get a little bit of pep in their step. And so maybe some of what we're seeing when we give patients steroids in the perioperative setting is, yeah, grandma's back hurt and we give her some steroids. Now she's just kind of fired up because of the steroids, and we don't notice that the back is bothering her as much. There was a 2008 study, and this is one of the better studies we have, that showed a trend towards improvement if you had low back pain with a positive straight leg raise test, really kind of honing in on the patients where we think there's nerve root irritation or inflammation. And so in these patients, they got an intramuscular dose of steroids, and there was a trend towards improvement. So for the grumbly low back pain, hey, I lifted a box, my back hurts up here. Really, I don't think steroids even have a kind of a theoretical role. But if you've got concern for nerve root irritation, and sciatica seems to be one of the signals that we can pick up on, that's a patient where I would think, do you have risk factors for complications associated with steroids? And if you don't, it might be reasonable to give a dose of steroids to these patients. Epidural injections, emergently, I don't know how to do these. I tell patients that I can put a breathing tube in you. I don't know how to do an epidural. We're not allowed to do these, but there really is not an emergent role. And again, that's because most patients, no matter what we do, are going to get better. If you don't have sciatica, really the literature would say that epidural injections don't help. If you have clear sciatica, maybe short term, but at a year, you're no better off, and the rates of surgery are same. So epidural injections can help, but probably temporizing at best. Mattress choice. I found this because I had a patient that said they bought 3 different mattresses because they were convinced it would fix their back pain, and this has been studied, and this is in the Lancet, and what they found is that it doesn't really matter. You don't need a firm mattress. Maybe medium is better, but this is expensive. Mattresses are a hassle to buy and to pull in and out of your house. So just tell patients, no, your bed probably doesn't matter. Bed rest. This is another one that comes up all the time. Should I have bed rest? Well, remember back to where we came from, it was thought in 1743 that being in bed was problematic. They kind of, sometimes we're wrong, but we start to get it right. But then what do we know now about back pain? So if you have low back pain without sciatica, so grumbly low back pain, no radiations, very clearly that if you can maintain your activity, and I tell patients, you don't have to run a marathon, but we want to do your activities of daily living. Your outcomes are better at 3 weeks and 12 weeks. That's without sciatica. If you have sciatica, and that's the subset of patients that often says, I can't get out of bed. You want me to exercise? I can't do anything. I can't move. If you have sciatica, that's the patient where we can say, all right, listen, it kind of doesn't matter if you rest some. I understand you're miserable. But if you resting for a shorter amount of time is going to be better. So for most patients, say, I don't know, just keep moving. We're going to use the pain medication to get you feeling well enough to move around. If you have sciatica, we can cut them a break. But again, we don't want you to lay in bed and get stiff, so move around as much as you can. Exercise is great. I love when a patient says, should I exercise? My answer is generally, yeah, you should definitely exercise. Overall, exercise helps most conditions. For acute pain, it probably doesn't matter. It may make your back hurt worse, but it doesn't make you worse. And in terms of chronic pain, exercise seems to be effective, and physical therapy comes up. And even in the urgent care, I've had patients say, can you refer me to physical therapy? And I'm happy to do it, because a lot of times that's just getting the patients moving around some. Now, a lot of times in the literature would suggest that when they stop physical therapy, there'll be a rebound of their back pain. But that's probably because they've stopped doing exercise, which does help with chronic pain. And then they're back to kind of their chronic pain state. So physical therapy is not magical, but doesn't seem to be associated with any risks at all for the patient. Acupuncture. I lived in Portland, Maine. Everybody wanted acupuncture for everything. It's poorly studied. I will admit it has been around for thousands of years, and there are millions of people who use acupuncture. The honest answer is that it doesn't seem to beat traditional treatments that we would use. Does it mean acupuncture doesn't work? No, it just means that I can't interpret what's been going on for thousands of years on another continent, and it's hard to do placebo acupuncture or sham acupuncture is the big issue we run into. Massage. I had a patient recently say, can I get a prescription for massage? And I said, I will write a prescription for it. I have no idea if your insurer will cover this. They didn't. But does it help? No, it doesn't seem to help acute pain. If you feel better going to Massage Envy and getting somebody to rub your back, be my guest, but it doesn't seem to make backs better. Actually, it may help with chronic pain. Maybe it's because getting massages is a nice experience, and when you're doing nice things, chronic pain does consistently get better, and it beats acupuncture. So that's good for the massage lobbyists out there. Chiropractic manipulation. I am not a chiropractor. I've never been in the office of a chiropractor. Here's my emergency physician warning. Never let anybody adjust your cervical spine. Let's take that off the table. Chiropractic manipulation, the literature is basically uninterpretable, at least in my hands. The mechanism behind chiropractic medicine, I'll just tease you with this. The industry started based on a seance. That's a little bit wacky. Is it right or wrong? It's not for me to say, but it's very hard when you have a whole separate kind of arm of managing patients to then shift that into modern medicine and say, well, okay, what does that mean to us? The answer is very, very muddy, but best we can tell from large kind of Cochrane collaboration analyses, if you have low back pain without sciatica, grumbly low back pain, maybe chiropractic manipulation of your lower spine is better than standard therapy. So maybe it's better to have somebody muck with your back down low compared to not. If you have sciatica, there's no signal of improvement. And if you have chronic back pain, there's no signal of improvement. So if somebody says, I'm really miserable, it's been going on 2 weeks, should I go to the chiropractor? I'd say, don't touch your upper neck. But if you want to pay to have them mess with your lower spine, maybe that helps. I don't really know. Surgery, a lot of patients say, this has gone on long enough, can I have a surgery? So really when patients are talking about surgery for back pain, other than the real ominous causes, it's, hey, I've got this bulging disc, should I get a discectomy for herniated nucleus pulposus? That's overwhelmingly the most common reason patients get a surgery. Compared to traditional therapy, it might help it a year, but as you go out from there, patients regress to the baseline. So it does not give you sustained relief. There is a trend in newer data. Surgical techniques have gotten a little bit slicker. There's a trend towards improvement, but it's not ready for prime time to say, yep, this operation will fix your back. Elective history, if you're going to benefit from surgery, what would that patient look like? They come to your office a couple times, say my back still hurts, it's week 5. So you need to have a clear herniated nucleus pulposus on imaging. You need to have pain that makes sense based on what we see is irritating your nerve roots. And then a corresponding neurologic deficit. This is not motor, but if you've got decreased sensation, that's not an emergency, but that would suggest that maybe a surgery would be more beneficial for you. And then no response at 4 to 6 weeks. That's what I tell patients all the time. You may need a surgery, you may need an epidural. I really, if you were my brother, would not send you for that short of 4 to 6 weeks because the Vegas odds are you're gonna be almost totally better by 6 weeks. Who needs an emergent surgery for herniated nucleus pulposus? Again, this isn't cauda equina, this isn't spinal epidural abscess, but are there cases where we'd say, yeah, you need to go. So if you have signs of a cauda equina syndrome, right? If the disc has propulsed into the cauda equina, progressive motor deficit, and really any motor deficits, so things like foot drop, bowel or bladder incontinence, they need to go. Intractable pain is tricky. Some surgeons will take folks to the operating room for that, but the signal in the literature is not strong. Things that we often will call surgeons about where we really don't need to would be sensory deficits or a fixed motor deficit. So if you have sensory deficits, that's not an indication for emergency. And if someone says, my foot drop started 6 weeks ago and I just came to see you, that's worth noting, that's worth talking to a surgeon during daylight hours, but that's not an emergency. So backs hurt, we don't know what to do, we don't know why backs hurt. We talked about looking with our history and our physical for evidence of badness in the patient's spine. And then in terms of treatments, nothing is great. And luckily, the tincture of time seems to be the best treatment. And let's close with kind of how do we talk about patients. And we talked about this a little bit earlier. Kind of reforming the narrative and really convincing patients that back pain is not a horrible disease. You're not going to be labeled with this diagnosis. This is a condition of being alive long enough for your back to start breaking down on you. I know that sounds grim, but this study I found is really interesting. Patient expectations as predictors of outcomes in patients with acute low back pain. Done out of Harvard, over 400 patients. And basically they gave them a little bit of a pep talk, but they did a lot of analyses of these patients to see what was your expectation of recovery, and they compared it to the patient's actual recovery. And what they found is that there was a near linear relationship between the patient's expectation of recovery and their recovery at 5 weeks. And what that means is that the patient who says, I don't think I'm gonna get better, in fact, didn't get better. But when you flip that, the patient that said, I get it, my back hurts, you told me 90+% chance I'm better at 6 weeks, I can probably get by with a little bit of medication, maybe some stretching, maybe some physical therapy. Those patients' chance of doing better was increased. It was associated with their mental outcome. This sounds very woo-woo, and I'm not a woo-woo guy, but this seems to be a very real signal here that if we can talk to patients and say, hey look, and I tell them, this stinks. I get that. I've had trouble with my back before too. This too will pass. We don't need to hurt you in the process by doing a lot of wild things. Again, this study says that that is actually associated. If they'll buy into that narrative, they don't have to like the back pain, but if they'll buy into the narrative that they can get better, there's a strong signal that they actually will get better compared to people who don't feel that way. So low back pain, let's close it up. We're gonna see a ton of this. If you're working tomorrow, if you're working the holidays, you're gonna see back pain. Most of these patients are fine. Give yourself credit for a detailed but brief history and physical. Look for the red flags. Those patients need testing like we talked about. The majority of patients are gonna be fine. Whatever combination medications you want to use is fine. And I kind of like it because all of the literature about this is messy. So you can we're all equally right and wrong with whatever we choose for patients. Just try to not hurt patients in the process and then educate our patients. I really think just talking to patients and saying, I get it, man, this is miserable, but I do think you'll get better. That seems to be the thing that has the strongest association with the patient actually doing better. Appreciate it, and we'll be back in just a sec and we'll talk wound care. Hey, afternoon. Happy Thanksgiving. I'm Matthew Delaney. I'm an ER doc at the University of Alabama at Birmingham. And my kind of dirty little secret is every Wednesday I'm a wound care physician in our wound care clinic. And I'll tell you, I've done this about 10 years now. I've Learned a little bit along the way, but when I started, I didn't know a lot. And part of the problem is there's not a board certification for physicians in terms of wound care. And it's kind of the Wild West. You really can kind of just put up a sign and if you're licensed, say, I'm a wound care doctor, I'd like to treat you. And it's interesting because I would think within medicine, there are a few areas where people really just say, I don't know anything about this. And wounds seem to check that box for most clinicians. We see wounds a lot, but it's the easiest thing. I think if I'm seeing a patient for 4 things and a wound is number 5, it's very easy for me to look at the 4 things and say, I don't know, I don't do a lot of wound stuff. And so what I want to talk about is the things that I wish I had known before I set foot in the wound care clinic on day 1. And this is kind of looking at the literature. These are the things that are most likely to show up no matter where you work, whether that's a primary care, whether that's a rehab facility, urgent care, emergency department. And these 4 things are very clear. We should all be very afraid of the diabetic foot. There really is one dressing we can use on every patient that will rule them all. It will help almost everybody, it will hurt nobody. When we look at a wound or an ulcer, and those are in my hands synonymous, but ulcers, we need to think about the 3 causes of ulcers and the 3 things we can do to help get that ulcer better. And then not everything red is cellulitis, and we'll walk through this, but these are the things that again and again in my clinic I encounter, and I really wish somebody had made simple for me before I got set up 10 years ago. So number 1 is we gotta fear the diabetic foot. This is a huge cause of morbidity and mortality for a lot of folks in this country. And if you look at the burden of disease, 1 in 5 patients who has diabetes will get a diabetic foot ulcer. And I looked up the definition, it's very simple. Do you have diabetes? Yep. Do you have an ulcer or wound? Yep. And is it on your foot? Which is almost always where these are because of the neuropathy. If you got that criteria, you have a diabetic foot ulcer. And again, unfortunately, 1 out of 5 patients with diabetes over the course of their life, and this is towards the end of their life, will get a diabetic foot ulcer. And the odds are horrible. It's actually worse than a lot of cancers. If a patient walks into your clinic and has a diabetic foot ulcer, their 5-year survival rate is 50%. No matter what you do now, the caveat is they die from complications of diabetes, not necessarily from the ulcer, but still, I look at a diabetic foot ulcer as a marker of end-stage diabetes. So 50% of these patients with diabetic foot ulcer are dead in 50 years, and if you in 5 years, if you survive in that half, there's a 60% chance you will have needed an amputation. So if you got a diabetic foot ulcer, your chance of dying is exponentially higher than somebody who doesn't have that. Your chance of losing a leg is very, very high. And why is that? And one of the big players here, the morbidity and mortality, is osteomyelitis. So really, for me, anytime I look at a patient with a diabetic foot ulcer, I do 2 things. I recognize this is a patient who has a risk of a very bad outcome over the next couple of years, but also I pause and think, could this patient have osteomyelitis? Because they have osteo, the whole timeline picks up speed pretty rapidly. So how do we figure out at the bedside who's got a diabetic foot ulcer and who has an elevated risk of having osteo? And some of this is common sense, and some of this was newer to me. So one of the things is the size of the wound. And this makes a lot of sense if you think about how does a patient with diabetic foot ulcers get osteomyelitis. We think of osteo as the kind of classically think of the hematogenous spread. And that's what kids get. That's how children get osteomyelitis. But for the diabetic, they have neuropathy. They're just banging around with their insensate feet in their ill-fitting shoes, and they get an ulcer, they get a blister, it turns into a big ulcer. And then over time, just the bed of the shoe, the insole, will impact the muscles, impact the tissue, and impact the bone, and you get direct inoculation. So it makes sense that if you have a bigger ulcer, the chance that you have osteo is higher, and if you have a smaller ulcer, it's lower. Now, when we talk about likelihood ratios, I think of a good likelihood ratio as greater than 10, and a good one to rule it out. And that's really what a lot of us want to do at the bedside. I want to rule out the chance that you have osteo. We want it less than or equal to 0.1. So a lot of these things in isolation don't get us there, but we'll talk about combining some of these things and using common sense, I think can give us some powerful ways to risk stratify patients for osteomyelitis at the bedside. Probe to bone, this was new to me, and this comes out of the podiatry world. So this is basically saying, look, if you can see bone, you can just bet that patient has osteo, because if I see the bone, that means your shoe sees the bone every time you step down. But a lot of times you have these kind of tunneling wounds or smaller wounds and you can't see the bone. So the idea is if I can probe to bone, if I can feel bone, that's going to be associated with an increased risk of osteo. And then the converse, if you don't have probe to bone, then the chance that you have osteo is lower. Again, it doesn't rule it out, but it's lower. One of the problems is I don't have sterile medical probes, but most of us do have swabs or sterile Q-tips. And you can really just take that, get the wooden end and see if you can feel it. And if you feel bone a couple times, you'll get a really good sense of, yep, I'm probing to bone. And a lot of times if you're saying, well, I don't know, it's kind of a deep wound, but I don't think I feel bone, you're probably right. That's probably a negative probe to bone, but this is a powerful tool we can use. Inflammatory markers, I don't love these. And really in the world of osteomyelitis, the role that these play seems to be in following patients who have known osteo in terms of are they responding to treatment. A lot of people use this to kind of rule out osteo at the bedside. I would say that the problem here is that you don't have enough specificity. So a lot of conditions can cause your inflammatory markers to be high. We don't regularly use these in our clinic. I don't use this in the urgent care or the emergency department. So if you want to use them, I'm not critical of that, but I would say don't feel like if you're sending a patient with a diabetic foot ulcer to see anybody, especially this in the wound care clinic, you don't have to get this. That's fine. If we think we need it, we can add it on, but this is not a thing you gotta have done before we see the patients. Imaging, x-ray, it's hard to believe because this x-ray is overtly positive for osteomyelitis. It's just eating up the calcaneus. But x-ray, when studied consistently across patient populations, isn't as reliable as we think, and that's a weirdly low positive likelihood ratio. I think if you see it, you're like, gosh, that's gotta be osteo. The literature says that's not the case. So do we get x-rays? And we'll talk in a minute about why I use x-rays and how I use x-rays. But routinely, if you're gonna send a patient to clinic, don't feel like you have to get an x-ray on these patients. MRI is kind of not the gold standard, because gold standard would be a bone biopsy, but MRI is kind of the gold standard in terms of non-invasive tests we can do. And the problem here is that a normal MRI, negative MRI, has a good actionable likelihood ratio. If you have a stone cold normal MRI, that's a low likelihood ratio, and I would actually stop and say, hey, whatever this is, there's probably not osteo. The problem is that the positive likelihood ratio is bad, and that's the real potential risk associated with MRI for this. Is a lot of stuff is abnormal if you MRI feet with diabetic foot ulcers. Osteomyelitis is abnormal, but also things like bone marrow edema, which you get if you bang your foot into your shoe every day a bunch of times. That also can look like infection. And so often we'll get patients that show up with an MRI and we'll put our heads together with infectious disease and say, hey, look, this may be osteo, but we actually can't tell. We have an abnormal test that doesn't directly tell us what's going on or what do we need to do. This is a fascinating study, and this has been a practice changer for me. We talked about in isolation, things like probe to bone, things like x-ray don't reliably help us rule this in or out. Doesn't answer that question if it's this osteo. But in combination, in the right patient population, I think these are powerful tools. So these were patients where the clinician, it was mostly physicians, but the clinician said, I'm concerned there could be a foot infection. That's exactly the patients we're talking about. You got an ulcer, we know that's bad. I'm worried, could you have a bone infection, could you have a foot infection? And what they did is everybody got a probe to bone and everybody got an x-ray. And this is a small study, but again, I think the results are really helpful for us. If you could probe to bone and you had a positive x-ray, we're off to the races. Positive likelihood ratio greater than 12, that's actionable information, at least enough to get them to orthopedists, into infectious disease. But this is the powerful part that's changed how I evaluate these patients. If your x-ray is negative and I can't probe to bone, outside of any other kind of wacky things, high fevers, pus pouring out of the foot, but if you've got a negative x-ray and no probe to bone, that's a very low negative likelihood ratio. Now, this is one study, this is a fairly small study. If we were to replicate this study, I don't think that negative likelihood ratio would stay that low, but I don't think it would change significantly. And so this is what I do for every patient, no matter where I work, whether it's my clinic, whether it's the emergency department. I will say, look, that's a wound, that's a diabetic foot ulcer, we've got to be worried, but if your x-ray is normal and you don't have a positive probe to bone, I at least will say we're not going to chase down osteo right now. One of the questions that comes up, and we get this a lot in clinic, we'll get calls from the emergency department or from primary care offices, and they'll say, well, I've got a patient with osteo, should I admit him to the hospital? And I'll tell you, in the past couple of years in our wound care clinic, I have not admitted a single patient from the clinic to the hospital for osteomyelitis, because the honest answer is we don't have convincing evidence that admitting patients with osteomyelitis improves their outcomes either short or long term. And one of the things that's fascinating, so one of the kind of hallmarks, the cornerstone possibly of treating osteo, or at least what I thought before I got into this gig, was, well, antibiotics. We got to give them antibiotics, we got to give them IV antibiotics. And there was a great Cochrane collaboration a couple years ago that said, I thought this was shocking. It said, let's not look at the route of antibiotics. Let's not look at antibiotic choice. Let's not look at duration. They couldn't reach a conclusion to support the use of antibiotics for osteomyelitis at all. They said, we actually don't have clear signal based on the literature that treating patients with any type of antibiotics, any route, any duration is going to improve outcomes for these patients, which is staggering. But really what I tell my patients the first time I see them, if I think they have osteomyelitis, is, look, we can do a lot of different things. We can send you to infectious disease, we can do a PICC line, we can do oral antibiotics by mouth, but ultimately, if this were me, I would get the infected bone removed. And the literature seems to support this. And we love the idea of being limb sparing. But I would make the argument that really, if you've got something that has a 50% chance of killing you at 5 years, maybe it's better to be a little more aggressive up front. Again, we don't have literature to say that that's necessarily the right move for all the patients. But this idea that I'm going to put you in the hospital, oh my gosh, I see the bone in your foot, that's been there for a long time. This doesn't develop overnight. So I think if you see these patients and you want to say, look, I'm going to maybe give you some oral antibiotics, something like doxycycline. Again, that's not going to fix this, but a lot of folks have a hard time saying, yes, infected bone, but I'm not going to give antibiotics. So if you want to treat them, I would say give them some oral antibiotics, give them return precautions, and refer them to the wound care clinic. But I would say that unless you think the patient's systemically ill, there is not convincing evidence that we need to hospitalize patients with osteomyelitis. What we do need to do, and we have low-level evidence, but there's a lot of anecdotal evidence, is that it's helpful to get these patients into clinics, specialized clinics. Again, I get it. In the emergency department, you're busy. In the primary care clinic, you're busy. You, like me before I got into wound care, really didn't like wounds or ulcers. And honestly, they can be a little bit gross. The benefit of the wound care clinic, I think the main benefit is that this is all we do. We focus on this. And when we look at how do we take a patient with a diabetic foot ulcer and help them keep their foot, we're doing a lot of stuff. We're sending them to endocrine. We're sending them to orthotics. We're going to podiatry. Maybe they have to go to infectious disease. A lot of these patients do really well with home health, total contact cast. There's a lot of stuff we can do, which I get it. If you're in the ED or in the primary care office, that's almost impossible. The amount of paperwork we do, we see not even that many patients in some clinics because the volume of paperwork is so high. But that seems to be the magic. If there's any magic to a wound care clinic, is we can focus and do the kind of boring details of things that do seem to help the patients have better outcomes. So if you're comfortable managing these in your office, that's awesome. But there are enough weirdos like me out there that feel free. I would never be critical of sending any diabetic foot ulcer to us because again, this is a really big problem that has a 50% chance of killing our patients at 5 years. All right, number 2 question we get all the time in wound care is, what dressing should I use? We get tons of consults. Hey, I'm comfortable with the wound, but I don't know what dressing to give the patient. And I'll tell you that I'm also not comfortable a lot of times picking the right dressing. I think the last time I checked, there were over 270 dressings that are FDA approved in the US. Because basically to get a dressing approved, you have to say like, did it kill the patient? If it doesn't kill the patient, the FDA will rubber stamp it and approve it. You really don't have to prove that it works. And it's very confusing because there are multiple manufacturers and they make overlapping products and they try to make it easy for us. And these posters are plastered on the wall of our wound care clinic, and these algorithms that honestly, even having done this for over a decade now, I cannot make heads or tails out of what they want me to do based on these flow charts. So if you're going to Google something like what dressing should I use, good luck. If you find a good resource, please let me know. I'm not aware of them, but there's a lot of information that just is very overwhelming. And rather than focus on these algorithms and trying to decipher it, let's just simplify things down. If we're thinking about, is there one dressing to rule them all? Is there an ideal dressing that will help almost everybody and hurt nobody? We really want to focus on what are the properties of an ideal dressing. So I call it the 3 W's. It needs to manage wetness, warmth, and it needs to kind of keep the wound well. So wet, warm, well kept. In terms of moisture, we want moisture to be taken off the wound bed, but we don't want it to dry out excessively. There is a dressing that'll do that. From a warmth standpoint, I didn't think about this, but there's very clear literature that wound bed cooling will slow healing. And so if you have a dressing you're changing all the time, you're actually cooling the wound bed several times per week or twice a day sometimes, that'll slow healing. And then well kept, we want to keep the outside world as far away from the wound as we can. So what is that ideal dressing? And if you ask folks, what dressing would you pick for a wound? There's one answer that all of us have been guilty of saying, and that's wet to dry dressings. And I remember when I first learned that, it was my second week as a 3rd-year medical student, and a surgery intern, and I was rotating with, said, if you ever want to feel smart, when they ask what dressing do you want, tell them to put a wet to dry dressing on there. I said, that does actually seem really smart. And it's not just me, this number is wild to me. If you look at all of the home health orders in the US, 42% of all home health orders, all orders for any indication, are written for wet to dry dressings. So a lot of us got the same teaching that that's the medical thing to do, is say wet to dry dressing. But the part of this that's even worse is that if you look, 78% of the time when a wet to dry dressing is prescribed and applied, it's given for inappropriate reasons. And it's helpful to remember what a wet to dry dressing is. It's a mechanical debrider, right? It goes on wet, you slap the dressing on there, and when it's time to change the dressing, you do actually kind of rip it off. Patients hate this. And it's not that there's not a subset of patients where they actually could benefit from mechanical debridement, but that's actually a small subset. Again, 78% of the time when we're prescribing wet to dry dressings, it's not for the right reason. So can we do better? And the answer is yes, and we can make it very simple in terms of the one dressing to rule them all. And the answer, next time someone says, hey, what dressing should I use? Say, doesn't matter to me, get a foam dressing. So I have no conflicts of interest, but I'll say the trade names just because that's what we call them. Mepilex, Aquacel are some popular ones, but then all the manufacturers have something with foam in it. So what I tell my nurses in the emergency department, go in the stock room, and if it says foam, put that on the wound, and that's gonna help most people, it's gonna hurt nobody. And the reason foam dressings are great is because they really hit the 3 W's well. So from a moisture standpoint, A foam dressing of Mepilex can take 7 to 8 times its mass and moisture. And so for most patients, they can actually leave it on for a week unless they've got a really kind of exudative wound that's draining. That may be a situation where you either do more frequent changes or look for another dressing. But for the majority of wounds, the diabetic foot ulcers, the venous ulcers, you pop a foam dressing on there, it's gonna handle the moisture well. The fact that you don't have to change it that often also helps with the warmth standpoint because you're not changing it twice a day, you're not cooling down the wound bed. And then the well-kept, there was a really interesting study that said, let's look at how many layers of dry gauze we need to keep bacteria from translocating from the environment to a wound. And it was somewhere around 46 layers of gauze, which is a crazy thing. Of course we can't do that. But when you look at some of these foam dressings, you do get some bactericidal properties, especially the ones that have some silver. Again, you don't have to find the one with silver, but there are plenty of products out there that will help keep the bacteria off, but also a nice foam dressing does give them a good cushion from the outside. So when we're talking about dressings, the 3 W's, make it really simple. Foam dressings will help the majority of patients, but there's not even a theoretical wound that would get worse from a foam dressing. So worst case scenario, they show up in our wound care clinic, we say, foam dressing didn't hurt them, but we can do a little bit better, change up dressings a little bit. Leave that nerdy detail to us. If you just foam dressing everybody, you're gonna be doing right by the vast majority of our patients. But it's really interesting, we talk about dressings and patients are focused on this. Most of our referring clinicians are focused on this. And what I tell patients is that dressings are fine. But I think of dressings as kind of the sparkles on an ice cream cone or an ice cream sundae. And the honest answer is if you've got an ice cream sundae that's not the flavor you want, it's dripping down your hand, it's hot, you had to pay too much money for this ice cream sundae, putting sprinkles on the top, you don't really care. So unless we look at the underlying reason why the patient has the wound, then putting a dressing on it doesn't really matter. But flip it around, if we can address the underlying issue, if you get the ice cream flavor you want, you get 2 scoops, then when you put sprinkles on top, that's great, that's an extra benefit. And I kind of think of dressings as that way. It's the sprinkles on top, but really we gotta get the ice cream correct, or at the end of the day, that patient's not gonna get better. So how do we do that? And the way we do that is we identify the patients with an ulceration. We look for what are the 3 main causes of ulcers, because there are 3 main causes, and then there are 3 things we can do for these causes. And if we do these, no matter where you practice, we're gonna help most of our patients, and certainly in the time it takes to get them from your office to our wound care clinic, they may be well on the way to getting better if we just look for what are the 3 causes of ulcerations. So there are pressure and neuropathic ulcers, and these are probably the most common, venous ulcers and arterial ulcers, and we'll walk through the different types. And I love this, I'm a simple man, I try to keep this simple. If you have a pressure or neuropathic ulcer, and this is for all these, whatever the cause of the ulcer is, the one thing we need to think about doing is reversing the cause as best as we can. So pressure ulcers, you know this story, I know this story. It's generally going to be the diabetic foot ulcers, right? I have neuropathy, I'm walking, my shoes didn't fit, I got a blister that turned into an ulcer. These are easy. You can get these if you have normal sensation. I had a guy I felt really bad for. His daughter got married and he got the wrong tuck shoes and he danced all night and really tore his feet up and had huge ulcers. And I said, "No, you have neuropathy?" He said, "No, I don't at all. It was a horrible night dancing." But I give that dad credit for dancing the whole night in undersized shoes. But the key when it comes to pressure ulcers is, again, this is gonna almost always be the feet. You can see them on the sacral D-cubes, different talk for a different day. Those are monsters that are hard to heal. But the ones on our extremities and specifically the feet, we just got to get them off them. They got this wound because there was too much pressure in certain spots. So how do we offload them? And I kind of think of this, there are a lot of different ways to do this. And what I love to do is a total contact cast, which is a very specific way to apply a cast. So basically what you do is, if you look at this picture, you're putting the cast tighter up top, so you're kind of offloading the foot internally within the cast. And these are very effective and patients do very well with these. The problem is, I don't know how to put this on. Our cast techs do this. It's a very specific, because it is a riskier cast to put on because you're shifting weight from the wound area to the rest of the leg. So you do run the risk of causing other issues. But if you've got this option and you got a wound that's non-infected, it's a pressure wound, and you can get a total contact cast, I would say go for it. But the reality is, I don't have these. We just got these back in our clinic after not having them for 5 or 6 years because we didn't have a tech that could do them. So what are things that you and I can do? And the answer is simple things seem to be very effective. So this is a 4-foot offloader. Darco is one of the people that makes these. I got no ties to them, but if you just type in 4-foot offloader, you can buy this for under $25 off the internet. I won't name the websites, but you know the sites. They'll sell you these for under $25. If you send a patient to a medical supply company, it's much more expensive. And you see that that's a crutch right there. So if you just offload patients, if they've got a 4-foot ulcer, but if it's a heel ulcer, if you just put patients on crutches, and a lot of it's just talking to the patient, say, listen, I think you got this from walking too much or not checking your feet or wearing shoes that didn't quite fit. So we just got to kind of undo that. 96% of patients with simple offloading techniques will be better in 70 days compared to about 110 days if you didn't offload them. So it's an easy thing no matter where you work to say, hey, you can get crutches at a lot of thrift stores will sell crutches. So it's a very inexpensive way, and especially the forefoot offloader, if they got a forefoot lesion, which a lot of these folks will get, very effective, very cheap way that does have evidence to say this will get patients better quicker. I like to start with pressure ulcers because they're the easiest, right? You don't have to be medical to pick up one. That looks like your shoe rubbed you. Great, that's a pressure ulcer. When we get into venous and arterial lesions, it's a little trickier, honestly, and there are some clues, but the real answer is there's some overlap. So if you have bad venous disease, the incidence that you also have peripheral arterial disease is not zero. And so we do see some overlap, but we can also keep these kind of separate because, again, what we do for these is going to be very different depending on, is this a venous ulcer, is this an arterial ulcer, is this more of a mixed picture? So one of the clues that's in the textbooks is we'll look for the anatomical location. So if you see venous ulcers, it's typically that gaiter kind of circumferential around the calf distribution. If you look at arterial, you're looking for areas, and I think of it as, is it far away from a major artery? So you're seeing kind of bony prominences, toes, the anterior shin, the lateral medial malleoli on the ankles. And again, there is overlap, right? The gaiter distribution does cover the anterior shin, but in general, location of the wound can get us kind of on the right path to make this diagnosis. One of the things, and the literature doesn't really report on this, but this does seem to be at the bedside very helpful, is this a painful wound? So if you have a patient that's got venous ulcers, they'll tell you like, oh, it's uncomfortable, I don't like it. If you have a patient with arterial ulcers, they will tell you, I am miserable. It could be a small ulcer like this one on the toe. They'll say, doc, I have this little thing on my toe, I can't sleep at night. Anytime a patient self-reports bad pain from a wound, I'm thinking, could this be arterial? And it's not just that they report the pain, but if you look at a wound, you're like, holy smokes, that looks painful. Yeah, that's probably arterial, or there's probably enough there to suggest there's an arterial component. I would work that patient up more. And again, look at this. This is in kind of watershed distributions away from major arterial flow. This looks hellacious. This looks incredibly painful to me. So if you see a patient that got a painful wound, it's in a watershed area, and you're looking at it and saying, gosh, I think this is arterial, what is the next step? Well, what I used to always do, and what a lot of guidelines, and this is an interesting area where the guidelines tell us to do one thing, but I'll tell you, my practice patterns and outcomes for patients would suggest we can do better than what the guidelines would tell us. The guidelines would push us towards getting ankle brachial indices or ABIs in these patients. And that's an easy thing for a lot of us to get because you can just order it and they'll go to the lab and get it done. It's also really easy to do at bedside. And also, this is published all over the place. So our clinic has this guide here that says, well, look, it's simple. You got a blood pressure cuff, you got a Doppler or an ultrasound to check the Doppler flow. And why wouldn't you do this at the bedside? You can get this information, and this is actionable information. If you look at this chart, it tells us what to do. This should be easy, right? If your ABI is greater than 1.4, we worry and we say go to vascular specialist. And if it's low, we say go to the vascular specialist. And in the middle, it tells us kind of treat the risk factors or who we refer. I love this. This seems very clear, clean, and very simple. The problem is it does not reliably help us identify patients who have arterial ulcers. Maybe ABIs, if we look at the literature, are helpful in identifying patients with claudication or worsening chronic peripheral arterial disease. But if you look in the text, and a lot of the guidelines will say check at ABI, but then below it, kind of in smaller print, will say don't use to exclude the presence of a clinically significant arterial issue causing the lesion. So if we're looking at an ulcer and we want to figure out is this arterial, ABIs can lead us astray, and here's how it works. So if you look at a patient that's got bad enough peripheral arterial disease to have an arterial ulcer, the chance that they've got vessel hardening or calcification is near 100%. The more medical problems you have, the harder your blood vessels or arteries tend to get. And so the problem is when we get ABIs on patients and you have calcification or hardening of the vessels, now a good tech doing these will pick that up and note that in the report. Hey, technically can't get ABIs because of vessel calcification. I'm not a good tech. I could get an ABI, I can get a number. But the problem is that if we have vessel calcification, which we almost certainly have if you have an arterial ulcer, we run the risk that your ABI will be falsely elevated. So if you do an ABI at the bedside and you're good at it and you get a low number, great. You've identified peripheral arterial disease. This is probably an arterial ulcer. If you get a number that's sky high, look at the top end of this chart, greater than 1.4, you said, gosh, that's too high. This has got to be because of calcification. But the risk here is that if you get a patient where their ABI, if you could get it without the calcification, the hardening, if their ABI should be 0.5, but because of calcification, you're getting a falsely elevated ABI, you may get a normal reading. We may get a normal reading in a patient with a limb-threatening arterial ulcer because of this vessel calcification. So I'm not opposed to getting ABIs, but I would say if you're gonna let your foot off the gas, if you think it's arterial to the point that you're getting an ABI, I think we can do better by our patients, and I certainly wouldn't act on a negative ABI because the literature tells us that's not a reliable finding to rule out the presence of critical ischemia causing an arterial ulcer, which can lead to death and lead to losing your limbs. So what should we do? What can we do better than an ABI? Ultrasound is good, not great. It's accessible, it's non-invasive. The problem is ultrasound is decent. These numbers really reflect proximal, kind of narrowing the proximal disease, but most of the stuff we see is in the lower extremities, down in the feet and the legs. Ultrasound does struggle down there. Point of care ultrasound at the bedside, I would say, based on the literature, is not ready for prime time. If you find an occluded vessel, you're better at it than me, but again, be very careful, especially with proximal disease. Ultrasound doesn't tell us a lot there. What's the right test? What gets us a lot of good information? And CT angiography is an amazingly helpful test. And my move has been now that if you've got an ulcer that I think is largely arterial, I actually go straight from the bedside to getting a CT angio. And I do it in the emergent or urgent setting. So I'll do it in the emergency department. If it's in my clinic, I'll try to get it the next couple of days because the literature tells us fairly clearly that once you get an arterial ulcer, you may have had peripheral arterial disease, you likely had it for 10, 15 years. But once you get an ulcer, the timeline speeds up. So it becomes more of an urgent emergent. It's not an occlusion in most of these. It's not an ischemic leg or a fully occluded leg that has to go to the operating room that night. But we do need to identify these patients. If we think, is there an arterial component? Who are the subset of patients that would benefit from going to see vascular? And CT angio is very sensitive, very specific, and it lets us look at a patient and say, gosh, you have something that probably needs an intervention versus you got scattered peripheral arterial disease, we just need to manage your risk factors. That's a big branch point. And we had this debate within our group about, is this the right next test? Because about half of my colleagues wanted to do ultrasound next as the next test or send them to vascular surgery to get ABIs, which seemed to be a little problematic. And I was big on the CT angio side of things. And one of the kind of comments I got was, well, that's going to be a lot more expensive if you go CT angio first. And there's a study called the DIPAD study, which is interesting. And so they randomized patients to either getting ultrasound first or CT angio first in the setting where they thought there could be an arterial ulcer. And what they found is that if you did CT angio first, you actually saved $400, which makes little sense because everyone would agree CT angio is a more expensive test. And what they found was even when the patients got the ultrasound first, the clinicians often didn't trust it and so then followed that up with the CT angio. So in terms of risk stratifying patients with arterial ulcers, I would say if you think it's arterial, you or somebody soon needs to get some imaging. I think CT angio is the right test. And there's, number one, you're gonna find the subset of patients that could benefit from seeing a vascular specialist. And number two, you might actually save money. It's not proven to be a more expensive test because again, this is actually the thing that gets us actionable information in a lot of cases. We talked arterial, let's talk venous ulcers. Again, classic venous ulcer right here. I don't know why they're putting a butterfly needle in their leg. That doesn't make a lot of sense to me. We don't do that. But if you look at this looks uncomfortable, but not horribly, horribly painful. And it's in that gator distribution. And you also see some of the kind of skin color changes. And so this, if you see this, that certainly seems like there's at least a venous component here. What do we do, right? So the problem is all of our veins lose their elasticity over time. Usually by the time you're 25, your veins aren't doing what we'd like them to do. And so you get this from the swelling, and then with some compression, we can get this better for you. What does that look like? So I have these socks. All of my nurses have these socks. These socks are fun. They make me feel maybe a year or two younger than I am. But in terms of preventing someone from getting venous ulcers, and specifically to heal a venous ulcer, this does not get you enough compression. It doesn't do what we need to do. So how do we, if we see a patient we think that's a venous ulcer, how do we compress these patients to get that wound healed? And there are a couple of ways. There are multiple different multi-layer wraps. You might have heard of Uniboots. That's a 4-layer wrap. There are different versions of what you can put on. These are great. We use these all the time in clinic, but the problem is that, I'm not trained to do these. Our techs and our nurses are trained to do these. And like with that total contact cast for offloading wounds, if you put an Uniboot or a wrap on in the wrong area and don't distribute the pressure right, you can actually cause other wounds. So for a lot of us, we'll see these patients in the urgent care and say, it's a problem. I remember Delaney said we should compress them, but I don't have a way to put these on them. And so here's something that's been a game changer for me. I will prescribe patients compression stockings and I'll write it for 30 to 50 millimeters of mercury. And I'll tell them go to a medical supply store because that does a couple of things. Number one, when you write it at 30 to 50 millimeters of mercury, most commercial insurers will cover that as a medical device. If you write it for less or just write compression stockings and they take it to the store, most insurers will consider that to be an item of clothing or some kind of flare. And so the cost is actually pretty notable. It's about $100 for a good pair of custom fit compression stockings. Again, long-term that keeps you from losing your leg, that's great, but the out-of-pocket cost is significant for patients. So if you can get the insurance to pick it up, that's great. Also at 30 to 50 millimeters mercury, that's enough compression that realistically we can start to see the wound heal. Less than that, really, we can kind of keep it at bay, but it's not going to heal. It's just not enough compression. And the other thing is, one of the big limiting factors with compression stockings is they're a real pain to put on. But if you go to the medical supply store, the techs and the folks that work there can walk the patients through some of the tips and tricks of how to get these on. So insurance will pick it up, you can get the wound healing, and then there's also a decent chance that they'll be more compliant if you have somebody walk them through, hey, this is what I would do to put this stocking on. All right, let's talk. We talked about dressing choices. We've talked about be afraid of the diabetic foot. We've talked about there are 3 causes of ulcers, 3 things we can do. Let's close with this, and I think we all know this, and I think we get this wrong a lot. And I myself get this wrong a lot, and we're gonna dump on the emergency department, which I try to avoid doing, but the literature is kind of bad here in terms of the emergency department's ability to pick up on this. But again, this is not just an us problem. I'm looking at primary care. You guys go down with this ship too. So this is the notion that just because it's being red means it's cellulitic. And the literature tells us that we often see red and think cellulitis, but we're often wrong. So we'll dump on the emergency department first. That's my home. 259 patients admitted from the ED with a diagnosis of cellulitis. Ultimately, when all was said and done, 31% didn't have cellulitis. And they look back at these cases, and this is where it gets really bad. 84% of the patients didn't need to be admitted. 93% of the patients received unnecessary antibiotics. And did some fuzzy math, but they said, you know, if you extrapolate this out, and I'll be honest, I think these numbers probably would hold at most emergency departments. 130,000 unnecessary hospitalizations worldwide, over $500 million. But when they went back and looked at the specific reason why the patient was admitted, in 82% of the cases, the treating clinician said, well, it was for IV antibiotics. Now, undoubtedly, there are cases where I see red, it is cellulitis, they need IV antibiotics. And I would say, we'll talk a little bit about how we figure this out, who actually has cellulitis versus something else that's making their leg red. But when we think about it, yeah, if you think a patient has cellulitis, they do need antibiotics. But this idea that they would need IV antibiotics is not supported by the literature. And some of this is just basic pharmacology literature. So if we think about it, we want an antibiotic that will get into their bloodstream. We want it to be bioavailable. And IV antibiotics, we know, get in the bloodstream. They're going through an IV into the patient's bloodstream. But a lot of oral antibiotics have high levels of oral bioavailability. So if you look, you need about 90+% oral bioavailability in order to really kind of fight off the pathogen. But the good news is a lot of the medications that we use for skin and soft tissue infections, things like clindamycin, doxycycline, even trimethoprim sulfamethoxazole, you're in the high 80s to low 90s in terms of oral bioavailability. So I'll tell patients, yeah, you might have an infection, but there's nothing to say, and there aren't studies to say that giving these patients, you know, take away the critically ill subset of septic patients. But for run-of-the-mill infections, even bad cellulitis, if I can get you started on a medication with good oral bioavailability, the reason for hospitalization that was cited in 82% of the cases goes away. So one of the things we can do better in terms of antibiotic stewardship is we don't have to abandon antibiotics for all cases of red legs or red arms, but we certainly can lean away from this impulsive, well, you're in the hospital, so we got to give you IV antibiotics. And what the authors of the study also looked at was, well, if you shifted away from IV antibiotics, which we know even a one-time dose of IV antibiotics has a higher rate of adverse events compared to oral antibiotics, they said, look, if you did this nationwide and tried to be better, you could prevent 5,000 cases of C. diff and 6 cases of anaphylaxis. It's nearly fatal per year. And this is kind of weird math, but again, I think that the underlying theme is consistent and seems to be true that not everything red is cellulitis. We often miss this, and it's hard to get this right all the time. But if we're gonna pull the trigger and say you need IV antibiotics, really we should default to, I'm gonna give you something good oral bioavailability first. And if you fail that, sure, we can always put you back in the hospital. We don't have to jump to that. One of the things that's staggering to me is if you look at skin and soft tissue infections across the US, there's a 20% bounce back rate for patients. So 1 out of 5 patients that we say, hey, I'm gonna treat you for this skin infection or this abscess, 1 out of 5 are gonna fail that first round of treatment. That's actually a really high bounce back rate. It's one of the higher rates of bounce backs to the emergency department, to the primary care office. And it's not that they bounce back and die, but still, they show back up and it's like, you did this thing and it didn't work. And so there's been a lot of thought and kind of research into, well, why is that? Why is this skin and soft tissue kind of world of problems associated with such a high bounce back rate? And one of the thoughts is, well, we're probably screwing it up. We're probably thinking it's cellulitis and there's an abscess. And so in that case, we didn't get source control. There's still a pocket of pus there. And so can we be better? Or really kind of how good are we at making this distinction about, hey, this is just cellulitis versus, no, I think there's an abscess there. And one of the things that's gotten pushed out that I think does have a role, but a limited role, is bedside ultrasound. I am not great at ultrasound. I feel very comfortable scanning something that's red and bumpy and saying, yes, this is cellulitis versus an abscess. But I don't know, is that just me thinking I'm better than I actually am? So this was an interesting study of 1,200 patients. This is out of an emergency department setting. And the good thing up top is that we're actually pretty good. Me and you clinically going in and saying, I think it's cellulitis, I think it's an abscess, we're actually certain and accurate a fair amount of the time. So that distinction, clinically we seem to be doing okay, and we're only uncertain about 8.6% of the time. So starting out, we're pretty good at saying cellulitis versus abscess with a decent degree of accuracy. So then the question is, well, if we're already good, does adding an ultrasound really change much? And when they take all comers, ultrasound is pretty sensitive and pretty specific, but not necessarily better than what we're doing clinically. So is it a tool we can use? Yes, but clinically we're pretty good. But when you look at certain cases, so when I walk out and say, I know what this is cellulitis, there's no abscess, based on whatever I did at the bedside with that ultrasound, I'm right most of the time, you're right most of the time. In fact, when we ultrasound those patients, our management only changes 1.2% of the time. So if you're sure what you got, you're probably right. You might be wrong, but you're probably right. And adding an ultrasound probably won't change management. But in the uncertain cases where you're like, I don't know, this is weird, maybe there's a little fluctuance, there's some induration, it's kind of hard to get a great exam, the performance of ultrasound drops significantly. So it becomes less sensitive but more specific of answering that question of cellulitis versus abscess. But I think the power is in that subset of patients, and remember, it's only about 8% of the time that we're uncertain. But if we're uncertain, that's where I would argue getting a quick bedside ultrasound, or if you need to send them for an ultrasound, that's fine too. But getting ultrasound, those patients actually changes the management a quarter of the time. So what we're doing clinically is good, but if you're scratching your head and I'm scratching my head, that's where ultrasound seems to have power. And again, we're changing management. A lot of times it means we're gonna drain something we didn't know needed to be there, or we're not gonna drain something. We may think it's an abscess and we ultrasound, we're like, well, that's just actually cobblestoning skin, that's just cellulitis, and we avoid putting a patient through a painful procedure. So the vast majority of patients don't need an ultrasound. But in that subset, that kind of 1 in 10, probably an ultrasound is helpful because when we're uncertain, because it will lead to better outcomes and less medical misadventures. All right, I told you we're gonna dump on everybody, not just the emergency department. So diagnosis of cellulitis, there are other studies out there that show, and this is an unfair study, honestly. These were patients that were sent by their primary care to a dermatologist with concern for, is this cellulitis? And the dermatologist kind of cherry picked it, and they wrote this study, which is unfair, but it does highlight a point that I think is interesting. And they said that, look, only 10% of the time when a primary care sent us a red leg, was it actually cellulitis? Now that's not fair. Dermatologists have a pretty good gig. You don't need, primary care is out there doing the Lord's work. Leave the primary care docs alone. But this study's out there. We saw the one that dumps in the emergency department. And what the dermatologists used this was a way to kind of do a victory lap. And what they were talking about is that all the time we're getting sent cases of what they call pseudocellulitis. And this was a term that was new to me when I started wound care, but this is a term that I use all the time now. And I'll give you the classic story. So you'll see a patient that says, hey, I get recurrent cellulitis. You're like, that's weird, why? I don't know, they've never explained it to me, but 2-3 times a year, my legs will get red, they'll get hot, they hurt. Is it both legs? Yeah, both legs hurt. What happens? Well, they put me in the hospital, and I'm there for a couple days, and I always get vancomycin, and then after a couple days, my cultures are normal. They were never positive, but I had normal cultures, and they sent me home after the weekend, and my legs got better, they weren't red. And what the patient is describing, I think, is a classic setup for pseudocellulitis. So did they have red hot legs? Yep. Did their legs hurt? Yep. Did they get hospitalized? Yep. They got vancomycin, that's true also, but they also were in bed elevating their legs for a couple of days. And really what the patient, and this has been studied, generally when patients are describing this, what they're describing is pseudocellulitis, and the most common cause of pseudocellulitis is stasis dermatitis. So basically, and I tell patients this, our veins lose their elasticity, you get swelling, and skin can only swell for so long before it starts to get angry, and then it can ultimately break down. And so if you look at this picture here, this is a great case of stasis dermatitis and a great case of pseudocellulitis. So you've got a unilateral spot, you got a couple skin lesions there. So I would look at this, and honestly, I would say, maybe that is cellulitis. Somebody thought it was cellulitis. They drew a marker around it to demarcate kind of the margins. But this is stasis dermatitis. And so a lot of these studies that say, you guys in the ambulatory setting have no idea what you're doing, in dermatology, we know that's because they're doing biopsies of these patients. That's cheating. But again, we got to think, this is kind of the basics of medicine. Talk to our patients, really listen to what our patients are telling us, because we can pick up a lot of these cases. This is one of the ones we'll commonly see. We'll get this sent from the office all the time to the emergency department. Gosh, they have really bad bilateral cellulitis. You'd have to have the worst luck in the world to get bilateral cellulitis, because think about that. You'd have to get 2 different pathogens, get in both your legs about the same time, and infect pretty similar distributions. I'm not saying that can't happen, I'm saying that's pretty uncommon. But again, I don't want to be overly critical. This is stasis dermatitis. If you look at this, I wouldn't fault anybody for saying, gosh, I think that might be cellulitis. So these cases of pseudocellulitis and specifically stasis dermatitis can be tricky, but do we have tools that can help us? And I love it when a tool or a clinical prediction rule just encapsulates common sense. And this is one that I don't even use this, but I like that it reflects our common sense. So how do you predict who has cellulitis versus pseudocellulitis? Again, this is just a basic practice of medicine. Is it asymmetrical, right? Bilateral, you gotta be really unlucky. It's very unlikely you got bilateral cellulitis like that patient who got admitted twice a year to get vancomycin. That's a pseudocellulitis. But if you have asymmetry, you get 3 points. Age, we know that the older we get, the more likely we are to get infections. So if you're 30, it's less likely, but if you're elderly and they just define it as over 65, you get 2 points. And then I love this, other infectious stuff. Basically, just get a history. Look at the patient's leg. If it's one leg and they're elderly and they report fever and chills, yeah, that does sound like a cellulitis. And so basically, if you have a lot of criteria, and this is again, just the normal practice of medicine, that's more likely to be cellulitis. But if you're not seeing asymmetry and there's no other infectious stuff and all you got is an elderly patient with 2 red legs, you can feel comfortable saying, hey, I don't think this is cellulitis. It could be, but it'd be a very atypical form of cellulitis, and almost certainly this is a pseudocellulitis. So what do we do with that? And this is tough, and I think this is where kind of the art of medicine is the best we've got. So do we need to admit these patients? No. But that's looking at a lot of these retrospectively. So if you had a patient, you saw some of those pictures of stasis dermatitis, if you've got erythema going all the way up the leg and the patient says it hurts and maybe I had a subjective fever at home, I think the better part of valor sometimes would be to say, okay, I'm worried about you, your heart rate is up a little bit, maybe it's because you're in pain, but maybe this is kind of brewing sepsis. So I don't fault somebody for saying I was clinically worried about this patient, so I admitted them in the hospital. That being said, we have no studies that say that admitting patients for cellulitis outside of the critically ill patient improve outcomes. So if you look at a patient and say, I don't know, maybe it's cellulitis, maybe it's not. If there's enough to make you say, I'm gonna do some antibiotics, I would strongly argue we should be doing oral antibiotics with high bioavailability and trying these patients as an outpatient at first. Very few patients are gonna come back with kind of a precipitous decline. They may come back, but the odds that they come back and end up in the ICU or operating room or the morgue are very low. If you're gonna do antibiotics, and I'll admit, I'm a wimp sometimes. I'll look at a case, I had somebody with really bad bilateral erythema, and they kind of had some soft infectious symptoms, and I just couldn't convince myself that this wasn't maybe that rare case of bilateral lower extremity cellulitis. So I put them on some antibiotics, but I think the key, and we're seeing this with all types of infectious indications, shorter is better. So what I'll do is I'll give a patient antibiotics for 5 to 7 days and say, look, elevate your legs, day 3, 4, if you're better, you can stop taking your antibiotics. It's one of these old wives' tales that you gotta take all your antibiotics or you'll breed resistant pathogens. That's not how resistance develops. So shorter is better if you're gonna do antibiotics for these patients. But I tell them, look, I'll do antibiotics, I don't mind at all. But we need to do other things to get you better. So elevating the legs, compressing the legs is probably the most helpful thing we can do. And I say, just take it easy. Watch TV this weekend, keep your legs up, because sure, we can do some doxycycline, that's fine. But if all we're doing is throwing doxycycline at a bilateral pseudocellulitis, we're not gonna fix the problem. So elevation, rest seem to be the big thing. The dermatologists, when they get interested in this and stop doing other elective cosmetic procedures, will sometimes talk about, do we do topical steroids? There's a risk of thinning the skin, but you can help with some of the stasis dermatitis. So if you're comfortable doing that, you wanna do that, it's a reasonable approach. But for most of these patients, really just elevating, staying off your legs, that's the most effective thing. All right, so wound care can get very complicated, but honestly, it's simple in the vast majority of cases. The 4 things we talked about, the things I wish I'd known before I ever set foot in the clinic: fear the diabetic foot. Remember, 50% of patients with diabetic foot ulcers are dead at 5 years. If you survive, 60% of those patients will have lost a limb or part of their limb. There is one dressing to rule them all. It's a foam dressing. The brand doesn't matter. Just say, get me the foam thing in the stockroom. That will help the vast majority of patients. It will hurt no patients. And then when you're looking at an ulcer, remember the dressing is a sprinkle on top of the ice cream cone. You gotta nail the ice cream in the ice cream cone. So is it a pressure wound? If it is, we wanna offload. Simple offloading works for the vast majority of patients. If it's arterial and you're thinking, gosh, that looks arterial, I would image that patient urgently or emergently, and CT angio is gonna be the most accurate test that really helps you drill down on, is this a patient that needs to see a surgeon or an interventionalist, or can we just adjust some medications on our end of things on the medical side? If it's venous compress and the 30 to 50 millimeters of mercury gets that covered by most insurers and will help heal the wounds. And then not all that is red is cellulitis. We don't need to be hard on ourselves. I think that this is trickier, and I think if you put the dermatologist front line, they would miss it as much as we do without their biopsies and their fancy office tools. But again, if you're gonna take a patient, think about, is this pseudocellulitis for cellulitis? And if you're gonna pull the trigger in antibiotics, look for things with good oral bioavailability, short duration, and you'll help the vast majority of patients. Thanks a lot.